Did you know there's this tiny gland right there in your neck, maybe the size of your thumb joint? It weighs almost nothing, less than an ounce, but it's basically acting like the master conductor for your entire body, sending out signals to, well, pretty much every cell, dictating energy, metabolism, even how your brain developed. It's quite amazing. We are, of course, talking about the thyroid gland. Its influence is just huge. So today on the deep dive, we're going to try and cut through some of that complexity. We want to pull out the really important insights, those moments that make you go, aha, and just the fascinating details about how this little organ works, why it matters so much to you personally, and maybe touch on how understanding it is actually pushing medicine forward.
That's absolutely the plan. Our mission here is really to get grips with the fundamentals, the mechanics of the thyroid hormones. How are they actually made? How do they talk to your cells? And this is key. How does the body regulate it all so precisely? Because that regulation impacts, well, everything. And yeah, we'll definitely look at some of the exciting new medical ideas emerging from all this knowledge.
Okay, let's start with the basics. Location. Where is this miniature powerhouse? If you gently touch the front of your neck, sort of below your Adam's apple, your voice box, you might feel it. It's often described as butterfly-shaped, right? 2 lobes on either side.
Exactly. 2 lobes connected by a little bridge of tissue called the isthmus, right there in the anterior neck.
Yeah.
Small, like you said, but packed with these specialized follicular cells.
And those are the hormone factories.
Those are the main ones, yes. They produce the 2 key thyroid hormones, T4, which is tetriiodothyronine, and T3, triiodothyronine.
T4 and T3. Got it.
Now, here's a really important distinction. P4, it actually has very minimal hormonal activity by itself. Think of it more like a stable reserve, a pro-hormone.
Like money in the bank rather than cash in your wallet.
That's a great analogy, yes.
Yep.
It's long-lived. It has a half-life of about 8 days. So it hangs around, ready to be converted.
Okay, 8 days. That's quite a while.
It is. And then you have T3. T3 is the active form. That's the cash. It's the molecule that binds to specific receptors, nuclear receptors, inside almost all your cells. And by binding there, it changes how your genes are expressed. It's basically giving instructions.
Instructions for what sorts of things?
Oh, all sorts. Speeding up metabolism, controlling protein synthesis, fat breakdown, carbohydrate use. And it's absolutely crucial for development.
Right. You mentioned development. So vital for babies and children.
Essential. Normal brain development, normal physical growth in fetuses and newborns absolutely depends on having the right amount of thyroid hormone. But it doesn't stop there. Throughout life, T3 and T4 are regulating how you process proteins, carbs, fats. Keeps the whole metabolic engine running smoothly.
So without them, things really go off track.
Very quickly, yes. Now, just briefly, there's another type of cell in the thyroid too, the parafollicular cells, or C cells.
Okay. Different from the follicular cells.
Correct. They secrete a different hormone called calcitonin. Its job is mainly to lower calcium levels in your blood if they get too high, responding to hypercalcemia.
Interesting. So a calcium regulator too, but the main event is T3 and T4.
Precisely. Calcitonin is important, but the T3-T4 story is central to the thyroid's broad impact.
Okay, so T3 and T4 are the stars. How does the thyroid actually make them? You mentioned follicular cells. What's the key ingredient they need?
The absolute key ingredient is iodine.
Iodine, like an iodized salt.
Exactly. You ingest iodine, usually as iodide through food, water, salt. And the thyroid gland is incredibly good at grabbing it. It actively concentrates iodide, pulling it into those follicular cells.
It's like a magnet for iodine?
Pretty much.
Yeah.
Inside the cell, an enzyme called thyroid peroxidase gets to work. It converts that iodide into a usable organic form of iodine. Now, picture those follicular cells arranged like beads on a string, forming a sphere. Inside that sphere is a space filled with a gel-like substance containing a protein called thyroglobulin.
Thyroglobulin, okay.
Thyroglobulin is rich in an amino acid called tyrosine. The organic iodine then gets attached to these tyrosine bits on the thyroglobulin. You get monoiodotyrosine, 1 iodine, and diiodotyrosine, 2 iodines.
So iodine attaches to tyrosine on this big protein scaffold.
Perfect. And then comes the coupling step. These iodinated tyrosines link together. If a diiodotyrosine couples with another diiodotyrosine, you get T4, 4 iodines.
Makes sense. T4, 4 iodines.
And if a diiodotyrosine couples with a monoiodotyrosine, you get T3, 3 iodines.
T3, 3 iodines. Simple when you break it down.
The chemistry is elegant, yes. And these newly formed T3 and T4 molecules stay attached to the thyroglobulin, stored in that central colloid space, until the body signals for their release.
How are they released?
When needed, the cell engulfs some of that thyroglobulin. Enzymes cleave off the P3 and T4, and then they're released into the bloodstream.
And once they're out in the bloodstream, They don't just swim freely, do they? I remember reading they bind to proteins.
That's right. They need transport. Most T3 and T4 immediately bind to specific serum proteins. It's like getting a chauffeur. The main chauffeur protein is thyroxine-binding globulin, PBG. It carries about 75% of the bound hormones.
PBG. Okay, carries the majority.
There are others too, like transthyretin, sometimes called thyroxine-binding prealbumin and albumin. They carry smaller amounts. But here's the crucial point again. Only the free hormone, the tiny fraction that isn't bound to these proteins, can actually get into your peripheral tissues and do its job.
So the bound hormone is like cargo in transit.
Exactly. It's not biologically active until it's released. We're talking about maybe 0.3% of the total T3 being free and only about 0.03% tiny of the total T4 being free.
Wow, 0.03%. That's incredibly small.
So measuring free T4 and free T3 is really what tells you about the active hormone level.
Precisely. Total levels can be misleading if the binding proteins change, but free levels reflect what's actually available to your cells. This is super important for testing. Okay, that makes a lot of sense. So the thyroid makes the hormones, ships them out mostly bound to proteins, and a tiny free fraction does the work. But who's conducting this whole orchestra? There must be a control system.
Oh, absolutely. A very elegant one, managed primarily by your brain and pituitary gland. It's a classic negative feedback loop.
Negative feedback, meaning the output slows down the input.
Exactly. The main player here is thyroid-stimulating hormone, TSH. It's released from specialized cells in your pituitary gland, which sits just below your brain. TSH travels to the thyroid and tells it, make more hormones, release them. It stimulates both synthesis and secretion.
Okay, so TSH is the accelerator pedal for the thyroid.
A good way to put it. But then, the levels of free T4 and T3 in your blood feed back to the pituitary. If free T4 and T3 levels rise, they signal the pituitary to reduce TSH production. The accelerator eases off.
Ah, so the hormones themselves put the brakes on TSH.
Correct. And conversely, if your free T4 and T3 levels fall too low, the pituitary senses this, the brakes come off, and it releases more TSH to stimulate the thyroid again.
A self-regulating thermostat, basically.
A very sensitive one, yes. And there's another layer, the hypothalamus. A region in your brain above the pituitary produces thyrotropin-releasing hormone, TRH.
TRH, what does that do?
TRH travels that short distance down to the pituitary and stimulates it to release TSH. So the hypothalamus gives the initial command, in a way. And guess what? Free T4 and T3 also inhibit TRH synthesis in the hypothalamus.
So the thyroid hormones put the brakes on at both the pituitary and the hypothalamus level.
Exactly. It's a double-check system to keep everything incredibly stable.
That's really quite sophisticated. Now, you mentioned earlier that T4 is converted to T3. Does that happen in the thyroid, or?
Mostly outside the thyroid. This is another fascinating detail. Only about maybe 20% of the T3 circulating in your blood is actually secreted directly by the thyroid gland itself.
Only 20%. So where does the other 80% come from?
It's produced in your peripheral tissues, places like your liver, kidneys, muscles. They take the T4, that reserve currency, from the bloodstream and convert it locally into the active T3 cache.
Wow, so individual tissues can fine-tune their own T3 supply?
Precisely. It allows for much more nuanced, tissue-specific control over metabolic activity. Rather than the thyroid flooding the system with active T3, it provides the stable T4 precursor and tissues activated as needed.
That's incredibly efficient. So let's dive into the cells then. How does T3 actually exert its effects once it gets there? You said it modifies gene expression.
Right. It gets inside the cell, sometimes by diffusion, but often helped by specific transporter proteins.
Transporters? Like gatekeepers?
Sort of, yes.
Yeah.
They actively move thyroid hormones across the cell membrane. One really important one is called MCT8. We know it's critical because inherited defects, mutations in the gene for MCT8, cause severe neurological problems. The thyroid hormones can't get into the brain cells properly during development.
That really underscores how important just getting the hormone into the cell is.
Absolutely. And remember that local conversion. A lot of the T3 that acts within a cell, particularly in the brain, might have actually been converted from T4 right there inside that same cell or nearby cells.
Okay, so T3 is inside the cell. What happens next? Where does it bind?
It binds to those thyroid hormone nuclear receptors we mentioned, the TRs. They reside within the cell nucleus. There are two main genes coding for them, producing TR-alpha and TR-beta isoforms.
TR-alpha and TR-beta.
Yes, T3 binds preferentially to these receptors, most isoforms anyway. And once T3 is bound to its receptor, this whole complex, the T3 plus the TR, then binds to specific sequences on your DNA. These sequences are called thyroid hormone response elements, or TREs, located near the genes that thyroid hormone regulates.
So the T3 receptor complex grabs onto the DNA.
And that act of binding changes how readily that nearby gene is transcribed into messenger RNA, which ultimately dictates protein synthesis. It can either increase or decrease the gene's activity.
Turning genes up or down. And do the different receptors, alpha and beta, do different things?
They do seem to have somewhat distinct roles, often based on where they are most highly expressed. TR-alpha, for instance, seems particularly important in bone development in the heart-regulating heart rate.
Ah, you mentioned bradycardia earlier with issues there.
Exactly, slowed heart rate in deletion studies. And it's involved in neural development, too. TR-beta, on the other hand, is found in high concentrations in places like the brain, the liver, kidneys, and importantly, the pituitary gland.
The pituitary. So TR-beta is involved in that feedback loop, suppressing TSH.
That's a key role for it, yes. It's also crucial for the development of the cochlea in the inner ear, and therefore for hearing.
Fascinating how specialized they are. Is it just the T3 and the receptor?
Not quite. It's even more nuanced. The way the T3-TR complex interacts with DNA is modulated by other proteins called cofactors. There are coactivators, which enhance gene transcription, and copressors, which tend to silence genes when T3 isn't bound. These cofactors add another layer of fine-tuning to the whole process.
Wow. Cofactors, receptors, transporters. It's incredibly intricate at the cellular level.
It really is. And that brings us back neatly to that idea of T4 to T3 conversion.
Right, the local activation.
Yes, because the enzymes responsible for that conversion, the deiodinases, are another critical control point. They basically dictate how much active T3 is available right there in specific tissues.
Deiodinases. Okay, tell me more about those. Are there different kinds?
There are three main types known, creatively named, type 1, type 2, and type 3. Dio1, Dio2, Dio3.
Okay, Dio1, 2, and 3. What do they do?
Dio1 is found predominantly in the liver, kidneys, thyroid, and a bit in muscle. It converts T4 to T3, contributing somewhat to circulating T3 levels. Its activity tends to go up in hyperthyroidism and down in hypothyroidism. It can also inactivate T3 to T2.
So it responds to the overall thyroid state. What about Dio2?
Dio2 is really interesting. In humans, it's found more widely pituitary, brain, brown fat, but also thyroid, heart, skeletal muscle. Crucially, Dio2 is thought to produce the majority of circulating T3 in humans by converting T4. And here's the twist. Its activity generally increases in hypothyroidism.
Increases. So when thyroid hormone is low, this enzyme ramps up to make more active T3 locally.
Exactly. It's a compensatory mechanism, trying to maintain T3 levels within cells, even when thyroid output is low.
Yeah.
Particularly important in the brain and pituitary.
That's a clever adaptation. And Dio3?
Dio3 is primarily an inactivating enzyme. It converts T4 into reverse T3, RT3, which is inactive, and also breaks down T3 into T2, another inactive form. You find Dio3 highly expressed in places like the placenta, the developing brain, skin, and skeletal muscle. It acts like a brake, protecting tissues from excessive thyroid hormone exposure, especially during development.
So you have activators, Dio1, Dio2, and an inactivator, Dio3, working in different tissues, responding differently to thyroid status. It's like every tissue has its own thyroid hormone thermostat dial.
That's an excellent way to think about it. It allows for incredibly sophisticated localized control. And just as a quick aside, these deiodinase enzymes require the trace element selenium to function properly.
Ah, selenium. So micronutrients play a direct role here too.
They do. Selenium deficiency can impair T4 to T3 conversion.
Okay, this is incredibly detailed. Let's shift to the practical side. With all this complexity, how do doctors actually figure out if someone's thyroid is working correctly? What are the key tests?
Well, despite all the intricate details we've discussed, the single best screening test for most thyroid dysfunction is usually the TSH level.
TSH, back to the pituitary hormone. Why is that the best?
Because of that sensitive negative feedback loop. The pituitary is exquisitely sensitive to circulating free T4 and T3 levels. Even small changes in free hormones cause much larger inverse changes in TSH. So the thyroid is underactive, hypothyroid, free T4, T3 will dip slightly, and TSH will rise significantly as the pituitary tries to stimulate it more. If the thyroid is overactive, hyperthyroid, free T4, T3 rise, and TSH gets suppressed, often becoming undetectable.
So TSH acts like an amplifier for small changes in thyroid output.
Precisely. It's usually the first thing we check. Then, depending on the TSH result and the clinical picture, we often measure free T4 and sometimes free T3 as well.
Free T4 and free T3 measuring the active fractions directly.
Yes. We sometimes measure total T4 and T3 too, But you have to interpret those carefully because of the binding proteins. Remember TBG?
Right, the main transport protein.
Its levels can change. For example, estrogen, like during pregnancy or from hormone therapy, increases TBG levels. This raises total T4 because there are more carriers, but the free T4, the active part, usually stays normal, and the person feels fine. TSH stays normal too. Conversely, severe liver disease or certain medications can lower TBG, decreasing total T4 without necessarily changing the free T4 or thyroid function.
So focusing on free hormones avoids that confusion. Makes sense.
Are there other tests?
Definitely. We often look for thyroid autoantibodies. These are proteins made by the immune system that mistakenly attack the thyroid. Antibodies against thyroid peroxidase, TPO antibodies, or thyroglobulin, TTG antibodies, are common markers for Hashimoto's thyroiditis, the most common cause of hypothyroidism in iodine-sufficient areas. Antibodies that stimulate the TSH receptor cause Graves' disease, the most common cause of hyperthyroidism.
So antibodies tell you about autoimmune thyroid disease. Yes. And one other marker, thyroglobulin itself, that protein scaffold where hormones are made, can be measured. It's mainly used as a tumor marker after someone has had their thyroid removed for thyroid cancer. If levels rise later, it might indicate recurrence.
Okay, TSH, free hormones, antibodies, thyroglobulin. Quite a toolkit. What about screening the general population? Should everyone get tested?
That's a debated topic.
Yeah.
Routine screening is recommended for all newborns. Congenital hypothyroidism needs to be caught and treated immediately to prevent severe developmental problems.
Right. Crucial for babies. What about adults?
For asymptomatic adults, large medical organizations generally don't recommend routine screening. The evidence that screening and treating mild subclinical thyroid dysfunction improves major health outcomes isn't consistently strong enough to justify universal testing. However, some experts do argue for screening older adults, say over 70, because the prevalence of subclinical hypothyroidism does increase significantly with age, and it might contribute to certain issues in that population. But it's not a universal consensus.
So targeted testing based on symptoms or risk factors, but maybe not broad screening for everyone without symptoms except newborns.
That's the general approach currently, yes.
Now, looking forward, all this incredibly detailed knowledge about receptors, transporters, deiodinases, how is it actually changing medicine? Are we seeing new therapies emerge?
Absolutely. This deep dive into the molecular mechanisms is paving the way for much more targeted therapies. Understanding the exact structures of the TR-alpha and TR-beta receptors and how they work differently in different tissues has been key. It's allowed researchers to design and synthesize selective thyroid hormone analogs, molecules that mimic T3, but preferentially bind to, say, TR-beta, or have properties that target them to specific tissues like the liver.
So drugs that could give you some benefits of thyroid hormone, but maybe avoid some side effects by being more targeted.
Exactly. That's the goal. For instance, there's been a lot of interest in TR-beta selective agonists for lowering LDL cholesterol, the bad cholesterol. The liver expresses a lot of TR-beta, which is involved in cholesterol metabolism. Drugs like epitirone were developed for this, though clinical development has faced hurdles.
Interesting. What other areas?
Well, non-alcoholic fatty liver disease, or hepatic steatosis, is another big target, again leveraging TR-beta action in the liver. Some compounds, like soberterone, are being investigated. There's even evidence these might help with obesity by promoting the browning of white fat, converting energy-storing fat into more metabolically active, energy-burning brown fat.
Turning up the metabolic furnace in fat tissue. That sounds promising.
It is. There's also research into heart failure. A compound called DITPA showed some promise in early studies, although longer trials revealed toxicity issues, highlighting the challenges. And the neurological field is really exciting too. Remember, the MCT8 transporter needed to get thyroid hormone into the brain. Researchers are developing analogs that don't rely on MCT8, potentially offering treatments for patients with MCT8 deficiency. There's also preclinical work suggesting certain analogs could promote myelin production, that's the insulating sheath around nerve fibers, which could be huge for diseases like multiple sclerosis, or even aiding recovery after brain injury.
Targeting myelin.
Wow. And any others?
Even wound healing. Some animal studies have shown that applying T3 topically can actually accelerate skin wound healing.
That's incredible, from systemic metabolism right down to healing a cut on your skin.
It just shows how fundamental thyroid hormone action is across the board. And while TSH and free hormones remain our clinical workhorses for assessment now,
You can see a future with more precise tools.
potentially, yes. Maybe one day we'll have better ways to assess thyroid hormone action within specific tissues, not just rely on blood levels. More tissue-specific markers or imaging techniques could emerge, but that's still further down the road. It really paints a picture of progress, moving from understanding the whole system to tweaking individual components for therapeutic benefit.
Well, we've certainly covered a lot of ground today, from the thyroid's location and basic hormones, through the intricate steps of synthesis and the sophisticated feedback control, all the way down to how T3 acts inside cells, the crucial role of deiodinases, how we test for problems, and now these really cutting-edge potential therapies. It truly highlights the elegance and complexity packed into that little butterfly gland. It really is the master conductor, isn't it?
It absolutely is. And maybe a final thought to leave you with. Just consider this delicate hormonal balance, our growing ability to understand it and potentially manipulate it, not just systemically, but at the level of specific cells and receptors. It really does open doors for a future of much more personalized medicine. Imagine treatments finely tuned not just to your condition, but to how your specific tissues are responding, using therapies designed to nudge the system exactly where it's needed. That's the promise held within understanding these tiny, powerful molecules. It's a profound thought, this hidden powerhouse inside us orchestrating so much, and how understanding those minute details, those tiny molecular interactions, could genuinely reshape how we approach health and disease. Really makes you appreciate the complexity humming away inside you right now.